we'll go ahead and get started. Can we, I want to welcome those that have just recently come into the room. I think you can see the title of the slide here. Thank you for coming to our speaker series today. Can we move to the next slide? Great. Okay, just to let you know, this webinar is in two different languages here. It's English and French. Please, at the bottom, you can select which one you would like to have. So please just go ahead and do that now. You can switch between the two languages just by clicking the interpretation button at the bottom of your screen. Thank you. Next slide. Great. So just to give a little bit more background, this is part of a larger webinar series hosted by the Global Watch Cluster Hygiene Promotion Technical Working Group. Today, we have a range of speakers that are going to be speaking today from MedAir, from ICRC, from Solidarities. Please feel free to put your questions in the Q&A box as we go along and reply via chat or the Q&A. The focus of this session today will be how hygiene promotion is integrated with other sectoral responses. We're not going into points about different messaging and best or not a deep dive, at least in those different messages or best practice. Rather, we want to look at just successful examples of how we've integrated hygiene promotion, including the challenges we faced. So with that, I think we can move to the next slide, and I'd like to start with Shannon Holding from MedAir.
Thanks, James. In this section, we're going to be looking at how hygiene promotion is implemented within emergency humanitarian responses that generally last for longer periods of time, say at least 1 year or more. I'll be specifically sharing about MedAir's work integrating hygiene promotion into care groups. So the care group model is an established social and behavior change communication approach that's been used by others in the emergency settings for many years. The original model is intended to improve maternal and child health and nutrition outcomes, so it's focused on reaching women of childbearing age or those with young children in the home. MedAir has been successfully integrating our hygiene promotion into this structure for many years and seen some really positive outcomes in that. So on the left, you can see a diagram that shows the basic care group structure where you see paid staff members working with incentivized promoters that then meet with their respective care groups. Within each care group is generally comprised of voluntary members of the community, and these people then participate in a specially designed lesson on a key message and are then commissioned to go out into the community where they meet with assigned neighbors. And that's how the messages are then cascaded out into a wider group. So within MedAir, that means that since we're using it for multiple sectors, from a community perspective, when you're having a house-to-house visit, only one structure is really coming to meet with you. You're not having promoters from different sectors come and give you messaging. The messages are rotated in a curriculum. It's generally new messages every 2 weeks, so up to about 26 messages a year. And we set that schedule up to address seasonal risks, like rainy season or other activities or heightened risk of certain diseases, as well as project activity timeframes, such as including safe water handling messages around the time of, let's say, NFI distributions. For now, I'd like to hear from one of our colleagues in Afghanistan on some adaptations that have been made to the care group model that have enhanced the effective behavior change outcomes.
Working in the Afghanistan culture setting present unique challenges to the care group approach. Over many years of running care groups, MedAir has learned that it's important to run separate male groups as well female groups. The goal has been to inform men, as they often have a decision-making role in the household. The more informed they are on the benefits of the behaviors we are promoting, the higher chance that the whole family will be able to adopt these practices. Sometimes they are simply not aware of the benefits of improved practices, or that some of their family members have additional needs at vulnerable times in their life, such as when children are very young. We have seen that including male groups in health and hygiene promotion has a positive impact on acceptance of the community and at the household level.
So some of the benefits that we've seen in integrating hygiene promotion into care groups have been the use of participatory adult learning techniques. That's part of the care group model and how we've designed the lessons. These are quite engaging lessons, have people active and engaging with stories and really able to adapt that to the local context and the barriers that people share within those lessons, so that it's not just information, but it's trying to encourage people to look at the common barriers they face and potentially share solutions that they may have within their own communities. We also have seen through monitoring real evidence of sustained adoption of those improved behaviors or practices that we're promoting, where people do seem to benefit from some of the social motivation and the structure around that care group model. And that applies to our hygiene practices as much as the other sectors. And that's encouraged us to continue to use this approach. We also do see advantages in coordinated messaging on some topics, such as disease outbreak or certain behaviors you want to be doing to prevent that disease transmission, and having the same key priorities highlighted prevents confusion or people wondering, well, someone said this and someone said that, so which is it? And being able to provide a really coordinated, clear messaging on what we would highlight as priorities for a community to address in their own behaviors and practices. When it comes to topics such as menstrual hygiene management or other things that may be more sensitive, we'll hear more about that from the next speaker, but we have seen that this care group model has also allowed us to address those more effectively, because we are already having a group of people that are comfortable talking about other topics, and they may, I'd say, warm up to sharing on a topic that is maybe not as openly discussed in their communities, and being able to learn from each other through that. So we've seen that as a really effective means to bring in more sensitive programming. It is also just an efficient use of human resources. We don't have overlapping promotion teams, and we're able to centrally manage and coordinate the resources that we need within that. And again, from the community perspective, they also have a connection with one person rather than a number of people that are coming to them. There's quite a robust monitoring mechanism that's part of the model that we do see as
Hi all, I'm seeing some
important in
issues
making
in the
sure that the
chat
quality
with
of the messages is
selecting
reaching the
the
people we think it is.
proper
But
language.
in
There are
terms
some
of
in the
integrating
English
hygiene
channel that
into
are
this or working
unable to
alongside
hear
other
the audio.
sectors, we don't
If
see
you
any
could please
disadvantages, and that's
select
mostly
the
beneficial for
English
including hygiene
slides at the
promotion in
top of
this
your Zoom
approach.
screen, as the audio is being
There are
shared
always
through the
challenges. So
slides.
some of those are that just by nature of working with other sectors means that the topics
So we
that
will
we're
go
sharing are
back
spread out
a slide or
throughout the
two
duration
for
of
better
the
context.
project. And so if you're having, drawing out
And please
linkages
message me if any of
between,
you have any issues.
let's say, specific WASH topics might be a bit more challenging to build on that. And looking at the schedule of when those messages occur can help, but it certainly means that you're getting less repetition or less building directly on all of the different WASH topics. It does require close coordination with other sectoral teams, and they all have their own priorities, and so that is always just an extra challenge. And it depends within Meta, we mostly work within integrated programming across these sectors, and that facilitates those sorts of discussions more easily. And like I have shared in the previous slide, our colleagues shared about working with male care groups. We generally might reach all households or a high proportion of households in a targeted area, but may not reach all community members with this messaging. So even if we have male groups and female groups, there would still be some populations that might be missing out on that topic. And so I think this approach is certainly best complemented by having some promotion at other levels, whether that's community events or at a facility or through another means, can definitely complement that. But certainly the model does allow us to reach quite a number of people that we feel are responsible or leaders in, let's say, the household family practices, and being able to help them be informed and motivated to take on those improved practices. So this concludes the topic for meta sharing about our hygiene promotion integrating into care groups. And we'll next hear from Sophie from Solidarities to learn more about their work.
Hello everyone, my name is Sophie. I am a Hygiene Promotion and Sanitation PM, and I work for Solidarité Internationale in Mueda in Mozambique. So we recently started introducing MHM and basic SRH as part of our more global hygiene promotion activities. So in this presentation, I'll go over how we gradually introduced this, and I'll explain the different steps of our pilot MHM and basic SRH intervention. The base of Mueda is located in Cabo Delgado in the north of Mozambique, and the projects are answering the needs of conflict-affected populations, of whom a big part are currently living in IDP resettlement sites, either in Mueda, Nangade, or Muidumbe. The current MHM and SRH activities have until now been implemented only in the 4 IDP sites surrounding Mueda that we can see on this map, because these are the sites where the hygiene promotion team had been intervening in the longest. What we would consider usual hygiene promotion activities in these sites that SI has been doing since 2021. It's door-to-door hygiene promotion through activistas, who are community volunteers, as well as mass hygiene promotion sessions, including group sessions, HP competitions, and local radio broadcasts. These sessions have always covered a variety of hygiene promotion themes, as we can see on the slide, including hand washing or the safe and correct use of latrines, but they never included MHM. So it's over the course of these usual HP activities that the field teams identified the needs and issues related to MHM and SRH, based on recurring complaints and requests. So first of all, there is a general lack of access to appropriate menstrual hygiene material, and it seems that the majority of women and girls in these sites are relying on a local cloth, which is called capulana, but which is very uncomfortable and painful, and it takes a long time to wash and dry. In addition, the team noticed widespread lack of knowledge and understanding related to these subjects, as well as persistent myths and taboos, which were having an impact on the health and hygiene practices of the women and the girls in the sites. And globally, this lack of material and lack of education was compromising the daily mobility of women and girls, for example, for activities like collection of water, going to school in the sites, and other activities in general. So it should also be stressed that one thing that we looked into was the alternative of disposable sanitary pads, because this was mentioned as the preferred option by the women and girls in the sites. However, as IDP settlement sites lack adequate waste management systems, it is not an ideal solution, and to this we should add that it's can only be a temporary solution, that in any case the access to markets is very limited for these women, and that it does put an additional strain on household incomes to have to buy this every month. In addition, we realized there was in general a lack of appropriate underwear for these women and girls to wear in the sites and to wear with the sanitary pads. So at the beginning of the year, SI partnered up with B-Girl. B-Girl is a social enterprise which has a subsidiary in Maputo and which has expertise both in the training in the area of MHM as well as in the creation of modern menstrual management products. So SI seized this opportunity through the funding of a BHA project, and the idea was to respond to both the lack of education as well as the lack of MHM material. So this is how in March 2024, SI's Hygiene Promotion team attended a training for trainers led by B-Girl. So covering in part the MHM and SRH topics of introduction to puberty, female and male reproductive systems, menstrual hygiene and the menstrual cycle, as well as how to deconstruct myth and taboos, how to facilitate such sessions and such sensitive topics, and how to present oneself when discussing about these issues. After this training, that SI team started implementing its pilot intervention. So it can be broken down in 4 main steps. First, awareness sessions and identification of focal points. Then distribution of menstrual underwear, followed by post-distribution awareness sessions as well as focus group discussions to gather qualitative data. And finally, the possibility of continuing this activity in the future projects. Due to the sensitive nature of MHM and SRH, SI decided not to include it directly into the usual hygiene promotion activities, but rather organize different MHM awareness sessions. So these sessions are covering the same topics, but condensed in a 2-hour session with a focus on the basic biology of the menstrual cycle, the link between menstruation and reproduction, and how to deconstruct myth and taboos. In providing these sessions, the team is heavily relying on the B-Girl material, and it should also be stressed that it is not at all intended to be an extensive SRH program, as the team is not sufficiently trained on these aspects to do so. So the sessions took place starting April 2024 with small groups of women, of girls, and then separate groups of men and boys in each neighborhood in the sites. The sessions were held in confidential spaces to ensure that everyone would feel comfortable and not observed by external spectators. When there were under 18 girls and boys, the consent was asked from the parents to ensure that everyone was aware of exactly what was being discussed. And then the final point was that at the end of these awareness sessions, SI identified some focal points in each neighborhood. The idea being that these people would be referenced to call Solidarité staff in case more information was needed, in case follow-up questions were being asked, and in general to cascade the information. This is just an example of part of the B-Girl training material that is being used during the awareness sessions. So B-Girl offers a variety of MHM material, and SI opted to distribute menstruation underwear with a mesh pocket in which one can put absorbable tissues. So one piece of underwear comes with 2 absorbable tissues, and the reasoning was that once one doesn't have these tissues anymore, capulana could also be inserted in the mesh pocket. This way, it's alternative that seems closest to the habits of the beneficiaries, all the while offering a much more comfortable solution. And the high performance fabrics are supposed to make it easily washed, dried, and reliable for 2 years. So these pieces of underwear were distributed over the course of April, May, and June 2024. Up to now, we have distributed 485 in the total of the 4 sites. During the distributions, there were awareness sessions also on how to wash, how to dry, how to change, how to avoid the risks of contracting any infection while using this menstrual material. So the empirical evidence regarding the effectiveness of these products in humanitarian settings and IDP sites remain extremely limited, and we have not yet gotten ourselves to the post-distribution awareness sessions nor the focus group discussions. So we don't have any data to analyze for now. However, it's still interesting to go over some of the expected benefits and challenges of this new approach. In terms of benefits, we are expecting a potential preference for these menstrual underwear over disposable sanitary pads and normally used capulana, as it's much easier to wash and dry, it's more comfortable, it's easy to change, and most of all, it is supposed to be a long-term solution. We're also aiming to have an increase in knowledge in general about menstruation and reproduction, which hopefully would lead to a gradual decrease in shame and taboos in the sites surrounding these subjects, as well as the removal of some mobility barriers and overall improved health and hygiene practices. On On the other hand, there's also an important number of challenges and difficulties that could actually pose problem with this intervention. So first of all, there's the insufficient quantity of pieces of underwear distributed, with only one per person, including 2 absorbable tissues. But this is not enough for one person to be able to change over the course of a period. In addition, we are in a context where washing and drying safely reusable products remains very difficult. There is a huge lack of water, with only 5 liters of water per person per day. There's lack of privacy with a lack of adequate shelters and latrines. There's a lack of hygiene items, including soap. And there's risks of items being rubbed if hung to dry outside in the sun. And to this, I would add that during the sessions, we've also had some complaints, not of people assisting to the sessions, but people hearing about them. And this shows that the topics still are very sensitive, that the taboos are there, and that it's very complicated to work on this, and that it will obviously take a lot of time before it's completely accepted as part of normal hygiene promotion activities. And then the last point to raise is that we had sensitive topics such as GBV arising during these sessions, which obviously is not very easy to handle, especially when SI staff are not trained to provide direct services on these matters. So the focus group discussions that I just mentioned, they will be planned very soon. We allowed for 2 months of use minimum to be able to have some relevant and qualitative data on the products. We hope that if there is a good satisfaction rate, we will be able to use these reusable MHM products in the future, in future projects and future hygiene kits. For the rest, we will continue identifying the problems. We will continue with the awareness sessions and gathering feedback on this. We hope that once we have enough acceptance and knowledge, we will be able to build a more holistic approach to address the MHM needs within the general HP activities. So thank you for listening. It was a lot of information and a very short time frame, but I hope it was clear, and I remain available if there are any questions.
The next section of the webinar will focus on acute crises, where there's a shift in all programming that also affects how hygiene promotion is implemented, where trained task force mechanisms are ready to be launched with roles and responsibilities outlined. That's ideal. But alongside that, there are individual actions that partners can take that enhance preparedness and the speed of our responses, especially around hygiene promotion. On the next slide, we'll look at an example from Somalia, where they've been implementing several cholera outbreak responses recently, and we'll be sharing some of their lessons learned.
In Somalia, we have been responding to 3 recent cholera outbreaks, cholera AW outbreaks, and there is a high risk of new outbreaks all the time. Steps that have helped to be prepared include keeping a pool of experienced community health workers, promoters that we can call up quickly, establishing SOPs and training materials for the health and hygiene promotion, and maintaining relevant IEC and messaging ready for deployment. The messaging into the community is an important part of the response to assist in reducing disease transmission and preventing new cases, while at the same time we are establishing treatment centers. We wanted to make every effort to reduce the number of patients needing that care. Being ready to start the community hygiene promotion at short notice is an important part of outbreak response, combining hygiene promotion with activities such as community-based surveillance and ORP distribution also increases efficiency of the response.
So I'll be looking at a few of the benefits and challenges that we found in integrating our hygiene promotion into our disease outbreak. The focus here is on scenarios where we don't have an existing emergency response mechanism or team in place. and looking at the preparedness that we can do, as shared with by the previous speaker, to improve our ability to respond. So it may be where we are integrating our hygiene promotion into an existing community outreach network, or where we are adopting health activities and bringing that into the scope of our existing hygiene promoters. So some of the benefits of that integration can be improved coordination, which may seem obvious, but we have seen many scenarios where if you have everyone involved, all the sectors are involved in the response, that we can more quickly link with the relevant coordination mechanisms to advocate for gaps that we find. So those needs are less likely to fall through the cracks than if, for instance, everyone active on the ground is from, let's say, just a health sector, and there's a community water supply gap, then having WASH actors present within that team and working integratedly means that we're able to have those contacts closer to hand and have a quicker response to address those issues. People also only receive one group of promoters for not just their messaging, but also surveillance and referrals, treatment options, as well as the preventative behavior messaging. So it can reduce not only message fatigue, but just coordinate the people that the affected population are interacting with and getting information from. And that sort of links with the next point, which is making sure that there is consistent messaging on what are those priority behaviors that this affected population should really be focusing on. There are slight nuances and variations even among the agreed general best practices, and that can be coordinated to be really clear and prevent confusion when we're working in an integrated approach. It also can allow for faster response because we're sharing existing staff members and may be able to, consolidate training and just as other logistical issues. In a related way, though, the challenges that we also face include just the natural limitations of how far any sort of promotion can reach within an affected population, in a disease outbreak. It's always going to be limited coverage, or often is. And when you're mixing a lot of other activities like surveillance as well as messaging, that can maybe further exacerbate the gaps when you can't cover everywhere, or it limits the time that people can give on some of the activities. So we do find that providing some sort of targeting of hotspot areas, or having a roving team that can go and target that, is obviously a good response. And working alongside our health colleagues can really facilitate that, because we can look at things like line listing. So similarly, there's a temptation possibly to add too many messages when you're working in an integrated approach. And in an outbreak response, it's even more important to really focus in on a small selection of really key content and keep that simple and clear what you want to emphasize. We also find that when we're working integrated, we can adjust those messages slightly based on the line listing and seeing who are the people currently experiencing high transmission rates, and maybe tailoring those messages based on that. And again, that becomes easier when you're already working closely alongside health colleagues. There are some limitations, obviously, in terms of how much we can be prepared within our funding mechanisms, how quickly we can change, especially when outbreak occurs outside of our normal working locations. But certainly some of these activities go a long ways to improving our preparedness and our ability to quickly provide effective hygiene promotion to reduce disease transmission rates. So our next speaker will share more about another approach to epidemic preparedness at the community level.
Hello everyone, I'm Monica Okwan from Kenya Red Cross. I'll be taking you through hygiene promotion with a One Health approach, which we implement in a program called Community Epidemic and Pandemic Preparedness Program, funded by USAID and IFRC. It employs a One Health approach, which is healthy humans, healthy animals, and healthy environment. In this initiative, we undertake a number of activities that include coordination meetings that are facilitated through One Health Technical Working Groups at the national level and at the county level, down to the sub-county level across the 6 counties. This committee is entitled with planning for the One Health activities, review of the One Health activities, and in case of any challenges, they are tasked to address the challenges with the policy makers and different levels according to the type of challenge. Through the program, we have reached 2,326 community health promoters who are based in the local communities, trusted by the community and part of the community. And also 261 community health assistants and 126 animal health assistants have been trained on epidemic control in communities and community-based surveillance, and they work together to identify cases in the community. For instance, if there are any cases on acute watery diarrhea, they are facilitated to report instantly, real time, through a digital platform using their mobile phones. The same community health promoters also conduct household visits, and they also conduct group sessions and visit schools on hygiene promotion and other related topics. 344 school health clubs have been established and their teachers trained, and they were facilitated with referral materials where they refer to during their sessions. The referral materials comprise of community case definitions, actions to be taken in case of an outbreak, and messages to be given to the community members. School-going children are great agents of change, for they never keep the information for their own use. They relay the information to their peers, to their families, and the neighborhood. And this also helps enhance reach and seeing a larger population reached with information on hygiene promotion. Private sector engagement has borne fruits in this project, where we've engaged 144 private sectors that include private health clinic workers and private veterinary practitioners. We initially trained them on community-based surveillance. They're able to identify cases in the community. They're also able to sensitize community members on what should be done across health and as well as hygiene and sanitation. In the schools that I've mentioned, among the activities that are conducted are hygiene promotion mobile cinemas, where learners are taken through and they watch videos on hygiene and sanitation. For instance, the steps of hand washing. And from that cinema, they're also able to take practicals and mention what they have learned from the mobile cinemas. This is an interactive session, and most learners like interacting with the cinemas. The cinemas also play a crucial role in knowledge retention. Dialogue sessions are also facilitated at the community level, where the community health committees take charge of mobilization together with the local administration. And the participants for the community dialogue include local community, key influencers in the community, key decision makers. And in this session, the community members are able to identify the challenges they are going through, especially on health, and them themselves come up with solutions which are workable to them. And in case there are resources required, they're able to identify the locally available resources to solve the problems they have. While community health promoters continuously visit households to make emphasis on hygiene promotion and address any other health gaps in the community that also include the zoonotic diseases and diseases that can be prevented by vaccines. This approach has seen us collaborate with other organizations. The county government has had collaborative initiatives with organizations like Dig Deep Africa and World Vision that support community-led total sanitation and also protect springs. The organization intend to have open defecation-free communities, thus contributing to hygiene promotion. 19 local radio stations are also engaged. The local stations convey messages in local languages that are well understood by the local members of the community. And these local radio stations are trusted by the community members. And we engage and share information through talk shows, feature stories, and also presenter mentions, amongst others. The local media stations have also supported and contributed to reaching more population with hygiene promotion messages. Our workforce is involved in hygiene promotion, that is the community health promoters who are from the local communities, trusted by the communities, and are also influential in the communities. Community health assistants and animal health assistants are the immediate supervisors for the community health promoters, while community health committees are in charge of governance of the community health units and also follow up on action plans developed and are also in charge of resource mobilization for their communities. While school health club teachers foresee activities at the schools, make plans for the health clubs, and also take part in supervision of the clubs. Why One Health approach? One Health approach has seen a multi-sectoral collaboration, and this has led to sharing of resources. A major challenge is limited resources, and when we are able to share, we are able to do more with the little. That's low cost and high impact intervention. The same approach ensures that we complement each other from the departments to the partners and also the government. Thus, system strengthening for enhanced epidemic preparedness, prevention, and response. The same approach trickles down to the community level, where communities are in charge of their health and are very crucial in making decisions pertaining their health and hygiene promotion initiatives and also sustaining the initiatives. Benefits that we've witnessed as we have implemented One Health approach are that counties have been able to launch strategic plans on water, hygiene, and sanitation. They have established WASH Hub, which is a coordinating unit for the WASH activities in the community. Also, for the case of cholera outbreak, counties that previously witnessed cholera outbreaks before the inception of the project have had a significant change in terms of the case fatality rate. For instance, in Bomet County, in 2015, their case fatality rate was at 1.7, while Tharaka Nithi at 0.8. But the most current outbreak, the case fatality rate was 0. Latrine coverage has also increased at 76%, while counties that include Bomet has seen a reduction in diarrheal diseases. Communities have been able to innovatively come up with activities to enhance hygiene promotion. For instance, constructing latrines that can withstand the loose soil, and also setting up hand washing facilities. We've witnessed a number of challenges that include climate change effects that has led to latrines collapsing due to waterlogging and flash floods. In some communities, due to scarce water, are not able to practice appropriate hand washing. Limited budgetary allocation towards hygiene promotion and the limited political goodwill towards hygiene promotion has been a major challenge. The social-cultural issues around latrine use, for instance, a daughter-in-law is not allowed to use the same latrine with their in-laws. Thus, in the absence of an alternative latrine, the daughter-in-law will definitely practice open defecation. It has been a journey, and we still embark on continuous advocacy, risk communication, and community engagement. A special thank you to USAID and IFRC for facilitating this and making it happen. And most importantly, to our communities that have led the process. Thank you.
Great. Let's say a quick thank you to the presenters for contributing that information. Really quickly here, I have a slide here just on the common challenges of integrated hygiene promotion. I want to make sure we're a little bit, I'm looking at the time here. I just want to make sure we leave time for Q&A, but we also just want to go over a few common challenges of integrated hygiene promotion. I think the first one there is key about doing formative research and barrier analysis. It depends on the team that you have. So it's one team, depending on the staff or the team that you have, it's difficult to give extensive barrier analysis on just particularly one sector because they're multi-sector. So you have to be careful about how you do that. And that's related to number two, that strong cooperation and coordination are needed because often the line management of these multi-sector things fall into one sector. And so they have different priorities, but you need really strong cooperation and coordination of one sector's line management, multi-sector kind of effort. And also it's just important to remember that data is managed differently by different sectors, say between nutrition and wash or something like this. So that's another challenge that comes out of this as well that we thought would be important to highlight. Can we move to the next slide? Great. So just to kind of wrap up and make sure we have time for questions, I just wanted to say, though those are the challenges, there are benefits as well. And I think one of the strongest benefits that I see is that the people that we're serving, the people that we're giving these promotion to and working with, they don't see us as separate sectors, health, wash, and nutrition. They just see one group. And so when we work together and coordinate well, they don't say, oh, the health team gave this message, the wash team gave this message. It's really us interacting as kind of one group. So I think it's really important to coordinate at that level because that's the way we're seen. But there are also efficiency of resources. It's really efficient to work that way together. It's better targeting. And there are just, and again, the logical link between, multi-sectoral kind of promotion, I think is very strong. So at this point, I really want to open up time for Q&A. I've seen a few questions in the Q&A spot, particularly here from Tom Russell, and I've captured one from Khadija as well. I think, Tom, your question came through first, and the first question was, how do we measure behavior change? After listening to everything, Tom, is that directed to one particular person, or would you just like to ask the panel itself, if you're still there? Okay, I can't hear Tom. So what can I do? So can I just hand over really quickly here to Shannon? Maybe you can ask that question since it came through probably during your presentation first. How do you measure behavior change? And how to measure the effectiveness of behavior change techniques that you use?
Yeah, thanks, James, and thanks, Tom, for that question. I think in some ways, I won't go into too much detail because this is about sort of how we give the hygiene promotion. We haven't covered too much about how we monitor that because equally when we're working with other sectors, we have different sort of monitoring approaches as well. So sometimes we've had to, do, let's say, a wash-specific monitoring of a population just to be able to make sure we're getting the data that we want to capture. And other times we're able to do that as an integrated, let's say a KPC survey or CAP survey. But in the simplest sense, how do we measure that change? It's looking for observed behaviors that we can. So we do look at that, let's say the reported knowledge that people have gained from the hygiene promotion, but really wanting to verify that. So let's say, people might talk about hand washing, but you want to be able to see a functional hand washing station or soap and water or other cleansing agent present in the household. So just looking to make sure that we're able to verify that.
Great. Thanks, Shannon. Sophie, would you want to add, or Monica, would you want to add, or we can go to another question? Okay. No, we can go ahead. I see, Tom, you put another question, but I'd like to go to Khadijah's question as well. That was in the chat, not in the Q&A. But again, it was asking about challenges that were highlighted in what we were doing in the strategy. So the question read, regarding the challenges highlighted, what strategies has the program used in addressing misaligned priorities with other sectors? I think this can be applied to each one of the presentations. Can I go to you first, Sophie, if you have an idea for that question, feedback? Sorry.
Sorry. Hello, can you hear me?
I can hear you, yes.
Sorry, would you mind repeating that? Because my internet connection is really bad, so I'm not sure I'm following everything.
Okay, sorry about that. And we just have a few minutes. I was saying the question read, regarding the challenges highlighted, what strategies has the program used to address misaligned priorities with other sectors? Is there some kind of, working with other sectors, how do you overcome those challenges? Really not hearing you well.
Hello.
So I'm sorry, Sophie, I'm not hearing you well. I think that means others aren't hearing you well either. I'm looking at the time, so I'm going to move on then. I think in the interest of time, we could ask one more question here with a few minutes to go, I think. Let me see, checking. For Monica from ICRC, maybe we can ask if I don't see any other questions here. No, maybe. Yeah. I thought it was really interesting from that presentation that the populations were really closely linked to their dependence on livestock. Have you encountered people being kind of a bit afraid or fears or anything about animal culling and could that result in disease if it's identified? Sorry, I think we're running out of time though. But if you picked up on that question, please feel free to jump in. Okay, what I'm going to do, can we go to the next slide? Since we're looking at the time and we're getting a bit at the end. So we have a webinar poll, so I'm going to hand over so that poll can go ahead and start. So hopefully you see the questions on your screen here. If you could please fill out these questions, it would be great. And as we are getting close to time and as you are filling out these questions, I just want to thank everybody for joining and your participation. And I think this slide will stay open until you complete it. And then I think this slide will stay open. The next slide is the ending slide. Yes. Thank you very much for your time.